We're getting
Okay. Our guest speaker today is Dr. Michael Ybarra, who is the Chief Resident in Emergency Medicine at Georgetown University in Washington, D.C. Has been the President of the Resident Section of the American Academy of Emergency Medicine. Was the 2010 Person of the Year for the American Academy of Emergency Medicine. Was the awardee of the 2010 Excellence Award for NOFAST, the National Organization in Fetal Alcohol Syndrome, for his work on legislation and testimony before Congress on the fetal alcohol syndrome, which is no small deal since the previous winner was the entire Cherokee Indian tribe.
You're a tribe.
Tribe. Was the 2010 and 2011 String of Pearls Award recipient, presented to the Best Resident Educator by the faculty of Georgetown University. 2011 Hugh Husey Award recipient, presented to the Best Clinical Educator based on voting by the graduating seniors of Georgetown University School of Medicine, and author of more than 30 publications.
Wow! Thank you guys all for inviting me to speak here. My name is Mike. I'm one of the chief residents at Georgetown in Washington. And I'm also a health coach with Take Shape for Life. So my life as an emergency physician is very different from being a health coach. It's almost opposite, because when I'm working in the ER, I'm taking care of people when they're on the edge, when they're coming in at the last breath, when things have gotten so bad that they need an intervention, that they need somebody to actually save their life. And Take Shape for Life is great because you're taking care of somebody when they're at a chance that you can actually make a difference. You can do an intervention that changes things, that takes them on a different path. So that's what I want to illustrate to you guys today. In emergency medicine, things can be pretty complicated. We got a lot of undifferentiated problems. We've got people that come in, and we have to sort things out. We have to take care of them, decide if they're sick enough to stay in the hospital or if they can go home. So to make things simple, we talk about the ABCs. Anybody know the ABCs? Doctors?
Airway
breath.
Always be closing and sales.
Yeah, always be closing.
Always be closing.
Airway, breath, circulation.
Emergency physicians, we talk about the ABCs. It's airway, breathing, and circulation. We like to make things really simple. But unfortunately, as people get bigger in the United States, it becomes harder. And I've got 3 cases, a little bit dramatic. These are real cases that I've taken care of where it's more difficult than normal to take care of patients because of their size and because of obesity. So the first patient I'm going to talk to you about was an airway problem that I had. And this was actually just a few weeks ago. It was a 54-year-old man that called 911 for trouble breathing. He was, an ambulance got to the scene in Southeast DC. He weighed 450 pounds, and he was in really severe respiratory distress. So he was having terrible trouble breathing. When the ambulance got there, the standard stretcher that they have, this was like an advanced life support ambulance, it could only hold 400 pounds. So his weight was 450 pounds, so he couldn't actually fit onto the stretcher. So the EMTs then had to call for backup to get a bariatric stretcher. So bariatric is a term, over the last 20 years, it's become very popular because it's, it's kind of like the term we use for obesity. So we have all these bariatric things now. We have bariatric stretchers, we have bariatric airway devices. There's a whole market for the bariatric devices. So once the bariatric stretcher gets there, the patient's actually getting progressively worse. So his respiratory status is getting worse. His vital signs are deteriorating. 15 minutes after the bariatric stretcher gets there, they have to carry him out. It takes 8 EMTs to actually get him out of his house and get him to the emergency department. So by the time this is all, by the time he's able to get into an ambulance and get to me, about 45 minutes have elapsed. So he's in the ER 45 minutes after the initial call was placed. And he's in pretty significant distress. So he's breathing very, very rapidly. He's sweating. And for me, when a patient's sweating and they're not running a marathon, they're not exercising, that's a really bad sign. So sweating is a sign that they're getting towards the end. He's not answering any questions because he's breathing so quickly. So this is not the patient, but this is an example of somebody breathing in really bad distress. You can see their sweat, and then this patient's really big. Their neck is really big. That means that in terms of airway, it's going to be really hard to take care of their airway. So we decide that the patient needs to be put on a ventilator. They're breathing so hard they need to have a ventilator help them breathe to get enough oxygen. The oxygen level is really dangerously low, so we think about ways that we're going to be able to take care of this patient. So there is actually, again, there's a whole volume of literature that tells us how to take care of people that are overweight when they need to be intubated and put on a ventilator. These are some of the techniques that we do. We put the bed all the way down. Normally it's just you're laying on a bed, but when you're really big, we have to kind of help. So put the bed like this. We tape people down. We have a number of people holding the patient. You have to ramp the head up so you get a good view of the airway. Managing the airway is one of the hardest things that we do. It's a lot of anxiety for us, and the bigger people are, the harder it is. So unfortunately, we're not able to get the airway. We're not able to put them on the ventilator. We can't get the procedure done. In my institution, we have a code critical airway because unfortunately this is all too common. So we call it code critical airway. More surgeons come, ear, nose, and throat doctor, anesthesiologist. None of them are able to get the airway either. And unfortunately, during this time, the patient dies.
Oh my
and all of this is because they're not able to breathe. So the second case is a case of breathing. This is a 25-year-old guy that I took care of. He was 300 pounds. He came to the ER for abdominal pain. So we took care of him. He spent a long time with us, and he was diagnosed with a condition called pancreatitis. Now, this is not something that you die from normally. It's actually something very treatable. So we took care of him for a long time. We gave him pain medicines and IV fluids, and he was better. He actually felt a lot better. He had a doctor. He was going to see his doctor in the office the next day. But he was pretty significantly overweight. So he went home, and overnight he became less and less responsive, more lethargic, and his family actually found him on the ground. He had passed out. So they, again, called an ambulance. They brought him back to the ER. When he got to us, he wasn't breathing. I actually saw him both days. I saw him day 1 and day 2, because I work flat. I'm a resident. So he was brought to the ER not breathing. We were able to get him back. We were able to get him intubated. But by the time he was in the ICU, he spent 2 weeks there, and he was seen by a number of specialists. And they diagnosed him with a condition that I was very unfamiliar with until this case. It was called Obesity Hypoventilation syndrome. And there's actually a condition when you become so big that your body's not able actually to breathe fast enough to get to the weight of your chest is too much to help you get enough oxygen to the rest of your body. So that was kind of an eye-opening learning experience for me. So he survived. He was able to go home, but he had to go home with one of those masks that you may have seen on TV, the CPAP mask, to help him breathe at night so he didn't have this episode again. And the final case has to do with circulation, the third part of this, the ABC. So this is a case of a 54-year-old woman who was 250 pounds. She came to the ER for chest pain. And she described chest pain as like a crushing, somebody sitting on her chest. She'd been overweight since she was 15 years old. So this is a lifelong problem for her for a number of years. She was on medications for diabetes and high blood pressure, so a very at-risk person, somebody that had been sick for a very long time. And the chest pain was very concerning to us, so we always get EKGs with chest pain. This EKG showed that she was probably having a heart attack. So we called a cardiologist. The cardiologist takes her to the cardiology lab, and they try and open up the blood vessels in her heart to make sure that the heart attack was taken care of. Unfortunately, her heart disease was so severe that they weren't able to do that. So at that point, they go to a cardiac surgeon. She required open heart surgery to create bypasses in her heart. She luckily survives. But after a long time in the hospital, she goes home with pretty severe congestive heart failure, because if your heart suffers a lot of damage from a heart attack, you can develop congestive heart failure. And so she went home and she required a lot of help from family and friends. So these are 3 cases of what it's like to work in the ER for me. These are cases of people that we're able to save some of the time. But even though we're able to save them, they still have a significant amount of morbidity. There's still a lot of bad things that happen to them as a result of their illness. So we could save them from their heart attack, but they're going to go home and have a lot of issues that they didn't start with. So hopefully today we can talk about ways that we can prevent all this from happening. So obesity in the ER is a big problem. For most of you, when you're coaching your patients, it's going to be talking about how you can help them get off their blood pressure medicine and diabetes medicines. But for me, I just want to tell you that obesity really does kill people, and I see it every day. And these are perfect examples of that. And even if it doesn't really resonate with you, I work in Washington. I work with a lot of politicians. I've taken care of a fair number of people that are involved in politics. And the argument that really works well in Washington is all about money. So that's the second part of this, is really the money part of it. And of course, in the United States, we have a huge problem with the budget. We're the largest, richest, and the most powerful country in the world. But we have a small or big problem. And that problem is the amount of money that we spend on healthcare. We spend about $2.5 trillion on healthcare every year. So $2.5 trillion is a big number. And the way that I think of it is, if you took $2.5 trillion and you took everything involved with healthcare, that's $2.5 trillion is everything related to healthcare. If you took that and you made it its own country, that would be one of the largest countries in the world in terms of economies. So this shows you the size of the United States economy, about $14.5 trillion. We would, as a healthcare industry, we would be about the size of the country of France. And that's everything that France produces. That's all of their healthcare, all of their cheese and their wine and all their good tourism. That's just healthcare in the United States. And one of the major reasons that we spend a lot of money on healthcare is obesity. So that $2.5 trillion, $350 billion of it, in a study in New England Journal about 2 years ago, came from obesity-related expenses. And that's about 15% of all expenses. And a lot of it has to do with the amount that we eat. So this is kind of the paradox of the plenty. We're a very wealthy country, so we can afford to eat very well. This was a graph from 1960 that shows the amount of calories eaten per day. And the lighter colors are countries that get less calories. The darker colors, the more red that they get, are the more calories people eat per day. So the United States is kind of orange to light red in the 1960s. But you can see by 2003 we are pretty dark red. In 1961, I think we were eating about 1,700 calories per day. By 2003, on average, Americans are eating 3,500 calories per day. So that puts us in the
Will you say that
2003.
1961, how much?
about 17 to 1,800 calories a day. And in 2003, we're up to about 3,500 calories a day. And so that's a big part of the problem. You can see that illustrated there. And so since we're eating more calories, people are getting more overweight, we classify diseases based on body mass index. So that's one way that we can kind of talk about this. And this is something that you've learned probably through your health coach training. We've got some good examples of it there. Body mass index is a standard way of reflecting body fat percentage. It's actually fairly accurate, usually within 4%, just as body mass. Does anybody know when it's not accurate, when body mass index?
Athletes,
bodybuilders.
Athletes, bodybuilders, and when you're pregnant. So those are the two situations that are really not that accurate. So BMI is kilograms per meter square, so it's just kind of like a calculation. And this is the graph that we're always taught that's in all of our Take Shape for Life literature. So less than 18.5 is underweight, 18.5 to 24.9 is normal weight, 25.0 to 29.9 is overweight, greater than 30 is obese. Now, I thought this was really interesting. I heard this in a lecture a couple months ago in my residency. Since we've gotten bigger and bigger over the last few decades, we actually have a new classification, and this is not a joke. So now we subcategorize obesity to severe obesity, morbid obesity, and super obese, which I think is really interesting that we call it super obese. It's like and that's, yeah, I've written that on charts before, and people think I'm joking, but no, that's people over 45, that's super obese, and there are a lot of people that are over 45. And as your body mass index goes up, you can see that the relative risk of death actually goes up significantly. So this is a graph just for white men, but the one for women is the same. Very similar pattern. It's a kind of U-shaped curve. If you're less than 18.5, so if you're underweight, your chance of dying goes up. If you're in kind of the normal range, you have the same risk of dying. But as you get above 25, your risk of dying from all causes just skyrockets. So it's up almost 3 times. And these are the reasons why. Obesity affects all of your organ systems. So you have a 35% risk of having a heart attack if you're overweight. You have twice the risk of having congestive heart failure. You have 85% of all high blood pressure is caused by obesity, and twice the risk of blood clots if you're overweight. In terms of your lungs, you can develop this condition I talked about earlier, the obesity hypoventilation syndrome. You can develop asthma, worsening asthma. You can develop sleep apnea, so have to wear those masks to help you breathe at night. You can develop chronic lung diseases. From a neurologic standpoint, you're at twice the risk of stroke. You're at 1.5 times the risk of dementia, which is actually really scary. That's something that really scares me. I mean, a lot of people are developing dementia, but this is something you can do by being a normal weight, lower your risk of dementia. More of a risk of migraines, peripheral nerve problems, and then finally this idiopathic intracranial hypertension. Just have to tell you about diseases that are fairly uncommon, but they're actually more and more common now. This is headaches for people that are overweight. This is kind of a special classification of headaches. Kidneys, people that are overweight tend to have a higher risk of renal failure. They have erectile dysfunction. That gets a lot of attention oftentimes. You can have problems with urinary incontinence, hypogonadism. From the endocrine standpoint, you can develop diabetes mellitus. And I love this. Originally when diabetes was talked about in the 1960s, type 2 diabetes, it was actually called diabesity, which is really appropriate because diabetes, too, is really a disease of the obese. So diabesity is kind of an appropriate term for it. It's not that common anymore to refer to it that way. We call it type 2 or non-insulin dependent diabetes, but diabetes is a good term. Menstrual disorders, infertility, and then pregnancy. You're actually at 2 times the risk of getting a cesarean section when you're obese and pregnant. And then actually at a higher risk of birth defects as well as a higher infant mortality rate. People that are overweight also have more GERD. They have acid reflux or heartburn. They can have fatty liver disease, so the fat actually goes into your liver, can infiltrate the liver and cause this fatty liver disease. You can develop gallstones. And then finally, from the standpoint of kind of the aches and pains, you're at more of a risk to have poor mobility. It's harder to get around. You develop gout a little bit easier. You can develop osteoarthritis. And then the thing that really bothers us a lot is the kind of chronic pain, the back pain, the neck pain, the knee pain, the ankle pain. It's just pain, 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 pain. So kind of in conclusion, I really enjoy taking care of the critically ill, but for me, when I take care of somebody that's really sick, it feels like a save when I help somebody that's a healthy 55-year-old athlete that has a heart attack because they have bad genetics. But it feels more like a miss when I'm taking care of a 40-year-old obese person that has uncontrolled diabetes and we're just trying to turn them around so they can go home. So that's where this program comes in. This is your chance to really help someone so that when they're coming to us, we can take care of something that they didn't have any control over. You have a chance to educate them about something to bring down the risk of having something bad happen to them so that they don't end up in the emergency room with a problem like those first 3 cases that I have. So with that, I'll turn it back over to our global directors, my parents, who are going to do next.